Everyone. My name is Weston Judd. My topic is diabetic ketoacidosis, specifically in type 1 diabetics. And this is for Nursing 7046, Professor Hoyson and Wright. Before we jump into the case study, I just wanted to do kind of a background of what is diabetic ketoacidosis. Diabetic ketoacidosis is a serious complication that is often associated with type 1 diabetes. This process occurs when the body does not have any insulin reserves and preventing glucose from entering the cell, causing starvation effect on the body. This starvation leads to hyperglycemia, lipolysis, ketogenesis, metabolic acidosis, and osmotic diuresis. Some of the classic signs and symptoms of DKA include the 3 Ps, which are polyuria, polydipsia, and polyphagia, which is frequent urination, increased thirst, and increased hunger. Abdominal pain, nausea, vomiting, Kussmaul's respirations, which is when you're taking deep, rapid respirations to kind of blow off the CO2 to help balance out that acidosis. A fruity smelling breath, which is acetone. Tachycardia and tachypnea, which goes along with the Kussmaul's respirations. And in severe cases, you can have an altered mental status. Some of the classic laboratory findings, to reiterate, is the hyperglycemia, metabolic acidosis, elevated anion gap, ketones present in the urine, electrolyte abnormalities, and kind of goes along with the ketoacidosis is you'd have an increased lactic acid as well. Some of the differences between DKA and HHS is hyperglycemia is usually greater than 250, whereas HHS is greater than 600. And then potassium is something that you need to keep an eye on when you go to initiate your insulin drip as well. Into the case study here. We have an 18-year-old previously healthy male presents to the emergency department with polyuria, polydipsia, nausea, vomiting, abdominal pain, and confusion over the past 2 days. His parents report a weight loss of 15 pounds in the last month, and he has been increasingly fatigued. The patient's respirations are deep, rapid, and a fruity smell. No prior history of diabetes. Patient recently cut his left leg while walking in the woods, requiring antibiotic treatment. The chief complaint, just to kind of summarize the case study, patient arrives to the ER with complaints of lethargy, frequent urination, dry mouth, abdominal pain, and fast respirations. History of presenting illness. The patient arrives with complaints of lethargy, frequent urination, dry mouth, abdominal pain, fast respirations for the last 4 days. The patient also reports a weight loss of 10 pounds over the last month and slight blurred vision. The patient rates the abdominal pain as an 8 out of 10 and is generalized in the location, meaning it is not in one quadrant versus another. Patient states that he is always hungry and thirsty, but nothing seems to help. Urination is frequent, but no burning or pain with urination. Patient states he feels hot and sweaty. That got worse throughout the day. Health history. The patient is currently not taking any medications, and he does not have any known allergies at this time. As far as medical history goes, no significant medical history. Social history, patient lives at home with both parents. And then family history, father has a history of type 2 diabetes and hypertension. Mother does not have any significant medical history that we know of at this time. This is my review of systems. So we have fatigue, weakness, a weight change of 10 pounds, appetite changes. The patient is flushed and warm to the touch. He has blurred vision, dry mouth. Cardiovascular, heart feels like it's racing. Respiratory rate is fast. Nausea, vomiting, very thirsty. Let's see. He has weakness, dizziness, anxiety, lethargy, and then once again we have the endocrine symptoms of frequent urination, always hungry, thirsty, And then that is all. Moving into the objective physical exam, vitals, heart rate is 126, temperature is 99.7, respirations are elevated at 42, BP is on the soft side of 100/68, SpO2 is 99% on room air, and the patient's weight is 60 kilograms and he is 72 inches tall. Observing the mouth, he has a dry oral mucosa, fruity breath smell, sunken eyes. He is alert and oriented but lethargic. He has abdominal tenderness that is generalized. Flush skin with foreskin turgor that is hot to the touch. Once again, the tachycardia and Kussmaul breathing pattern. Equal but weak extremities. Moving into the laboratory studies, we have a point of care glucose of 435, anion gap 28, which is elevated. Urine ketones are positive. The sodium is 130, chloride is 92, potassium is 3.1, hemoglobin A1C is 7.3, and the lactic acid is 4.9. And some of the significant aspects of the ABG, we got a pH of 7.11, CO2 is 26, and then we have a bicarb of 15. Into the problem list, we have tachycardia, Kussmaul breathing, polydipsia, polyuria, polyphagia, hypotension, open anion gap, hyperglycemia, hypokalemia, positive ketones in the urine, metabolic acidosis, and lactic acidosis. The differential diagnosis that I came up with, obviously diabetic ketoacidosis, dehydration, hyperosmolar hyperglycemic state, but given that it's not over 600, less likely. And then starvation, ketosis. This is also less likely because the patient is not purposely starving himself. Kind of to summarize the primary diagnosis, given the patient arrives to the ER with glucose of 435, that has me believe DKA over HHS, like I previously mentioned. The patient has a fruity breath odor and Kussmaul breathing pattern, which are cardinal signs of DKA. The patient also reports polyuria, polydipsia, polyphagia. The patient reports having nausea, vomiting, as well as abdominal pain. The patient is lethargic and weak in all extremities. The patient has metabolic acidosis that is uncompensated with a CO2 of 26, bicarb of 15, and a pH of 7.11. Lactic is elevated at 4.9. Plan, I kind of broke it up into non-pharmacological and pharmacological. So non-pharmacological, we got ECG monitoring due to the hypokalemia and tachycardia, SpO2 monitoring, serial labs. So when you are starting some of these medications, it is important to get follow-up evaluations to make sure the treatment is improving. So repeat lactic acid after the post bolus. We have potassiums Q4, hourly glucose while on the insulin infusion, and VBG, ABG to monitor that acidosis as well. Hourly blood pressures as needed, and neuro checks given that lethargy and altered mental status. And plan, as far as the pharmacological aspect, IV hydration is going to be one of the first things that you're going to establish. Pretty much when the patient rolls in, you're going to get a glucose, and then you're going to start a couple of IVs and get fluids going. Depending on where you're working, you can use normal saline. If you're at a teaching hospital, a lot of times they don't use normal saline. They use LR or plasma light or Normasol, given that normal saline is actually acidotic. But for the purposes of this, I just went with the normal saline. You're going to go at roughly 10 to 20 milligrams per kilogram per hour for the first dose. If the patient is symptomatic, tachycardia, hypotensive, Kussmaul's respirations after first bolus, you'll go ahead and repeat another bolus, given that there are no other contraindications, such as heart failure. This patient has a potassium of 3.1. If he's able to tolerate PO potassium, we would want to go ahead and give him 40. If the patient is not able to tolerate potassium, we would want to start IV potassium at 10 milliequivalents per hour, assuming he does not have a central line. Now, obviously, if he has a central line, we can go at 20, but for the purposes of this patient, we're going to go at 10. Just for some symptom management, we can give 4 to 8 milligrams Zofran IV every 6 hours PRN. Typically, the way that I've seen it used in practice is if the patient is just nauseous, you give 4. If they're actively vomiting and they don't have a prolonged QT, let's go ahead and give 8. When the patient's potassium is above 3.3, we can start that insulin drip. We're going to start that at 0.1 units per kilogram per hour. And this is when the hourly finger sticks come into play. When the glucose falls below 250 milligrams per deciliter, add D5 half normal saline. And you're going to start this at a rate at about 150 an hour. And depending on where you work, you're going to decrease that insulin infusion to 0.5 units per kilogram per hour. And you want to maintain a glucose of 150 to 250 until that anion gap is closed. Once the gap is closed, this is when you're going to bridge the patient off of the insulin drip. So you're going to have a basal insulin bridge of Lantus. And this is going to be 0.2 to 0.3 units per kilogram. Like I said, when the anion gap is closed. And typically, you don't want to do this until the patient is able to eat a meal. So you would want to give the Lantus, wait about an hour, and then feed the patient, give them sliding scale at the same time when you turn that insulin drip off. And like I just said, you're going to start that fast-acting Novolog sliding scale insulin with the meals. I put a 0 to 10 unit sliding scale. I've worked at many different hospitals and it varies widely. But that's all I got as far as the treatment plan with medication. Follow-up, referral to endocrinologist for insulin management. Diabetes educator prior to discharge is very important for these patients. This patient does not have any medical history prior to this, and they're not going to know how to check their glucose. They're not going to know the importance of counting carbs. They're not going to know the importance of keeping up with their insulin, and they're not going to know the signs and symptoms of hyperglycemia versus hypoglycemia. Nutritional consult. This is going to help them kind of get a better grasp of what foods are higher in carbs versus foods that are not, and this is going to help them stay on a steady diet as well. Primary care follow-up. This is going to be 1 to 2 weeks post-hospitalization, just to kind of get it a baseline with the patient. And if this patient is in high school, you want to coordinate with the school nurse as well, and establish a plan together. The list of some of the community resources that I found. So we got the American Diabetes Association, Beyond Type 1, Diatribe, Centers for Disease and Prevention. So the CDC has a tab on diabetes that has a lot of good info. And then for some reason I couldn't get the hyperlink on this one to work well, but Breakthrough T1D, and this is like a local chapter. That is the Central and Southern Ohio chapter. And here's a list of my references. If you guys are curious and want to look up at quick and easy information, I would recommend tamingtheshrew.com. That is, it's resident based, but it has great info that is easy to understand.